So, what is the aim of management? First is correction of hypoxemia. Improvement of airflow obstruction. And prevention of progression or recurrence. So we'll start with focused history. In history, we'll ask about the onset of exacerbation, frequency and severity, current medications, potential triggers, for that we'll do a clinical assessment. The physical examination with vital signs, presence or absence of breathlessness, use of accessory muscles, anxiety level, and any alteration in mental status. So after reviewing with history and examination, start with the treatment. So first management is giving supplemental oxygen. So first is giving oxygen to treat hypoxia and monitor saturation to maintain it more than 92%. Oxygen can be given by mask, by nasal cannula, or by BiPAP, or if needed, start ventilation by intubation. Then the medication. Start with inhaled short acting beta agonist. Example is albuterol nebulization. They act as a bronchodilator. So here we are doing bronchodilation in the dose of 0.15 mg per kg every 20 minutes for total 3 doses. Means for the duration of 1 hour, we will give nebulization in every 20 minutes. Then 0.15 to 0.3 mg per kg every 1 to 4 hours as needed. Give systemic corticosteroid. So they will act as anti-inflammatory short-acting beta agonist were bronchodilator. Systemic corticosteroids were anti-inflammatory. So we can start with dexamethasone or methylprednisolone. In 0.5 mg to 1 mg per kg every 6 to 12 hours as needed, determined by the condition of the patient. We can give 6 hourly or we can give 12 hourly. They are in IV doses. If patient can take orally, we can start oral prednisolone. After stabilization, in a dose of 1 to 2 mg per kg per day in divided doses for 3 to 7 days. Fourth drug is anticholinergic. They will act as mucolytic or they are bronchodilator as well. But we don't use them as a first line therapy. They are used as added therapy. If there is no improvement after albuterol and systemic steroid, then we add ipratropium. They will be given as nebulization in the dose of 0.5 mg every 6 to 8 hours as needed. If still there is no improvement, then injectable sympathomimetic they are also bronchodilator. Example is epinephrine. We'll give them in extreme circumstances. Epinephrine or adrenaline. One mg per ml solution of 1:1000 dilution. Give in a dose of 0.01 mg per kg IM stat may repeat if needed. If still there is no improvement, other medications we can add. It is magnesium sulfate. Given the dose of 25 to 75 mg per kg over 20 minutes. Maxelf should be given as slow IV infusion. Slow infusion under cardiorespiratory monitoring. Because Maxelf has a serious side effects. They can cause flushing, hypotension, headache. So these are the medications. Short-acting beta agonist for the treatment of acute severe asthma. After that, systemic corticosteroid, anticholinergic, injectable sympathomimetic, and magnesium sulfate. And after that, risk assessment of acute severe asthma. We can shift the patient to ward or we can discharge if physical findings become normal. There is no use of accessory muscle. In PFT, peak expiratory flow is more than 70%. Oxygen saturation more than 92% when breathing on room air. Breathing in room air. So these are the criteria for discharge. So this was about the management of acute severe asthma. Let's start with the next topic. Management of ventricular septal defect. 5-mark question. Ventricular septal defect. So before starting the management, we'll know something about the VSD because initial description is important for starting the management. So what is VSD? It is the developmental defect in the interventricular septum wherein a communication exists between the two ventricular cavities. Leads to shunt formation. Leading to shunt formation. So what are the types of VSD? Because management will depend upon the types of VSD, so we'll know about the types of VSD. So there are two types of classification. There are various types of classification, but two types of classification are important. So types based on their location. Based on location, there are 4 types of VSD. First is perimembranous, which is most common location. Muscular, inlet type of VSD, which is also called as atrioventricular canal VSD. And outlet, which is also called as infundibular. In classification is based on size. So it is in relation to the diameter of aortic annulus. The size is in relation to the diameter of aortic annulus. It is of 3 types: small, moderate, and large VSD. In small, the dimension of VSD is less than 1/3 to the diameter of aortic annulus. Or we can say it is less than 25% to the diameter of aortic annulus. In moderate, it is between 1/3 to 2/3 of the diameter of aortic annulus, or 25 to 75% of the diameter of aortic annulus. And in large, it is more than 2/3 of the diameter of aortic annulus, more than 70%, 75%. Management. Come to the management of VSD. So management of VSD depends upon site, size of VSD, and most important, magnitude of shunt, or we can say hemodynamic significance, whether it is hemodynamically significant or not, or we can say depend upon pulmonary vascular resistance. Start with small VSD. So what was small VSD? The diameter is less than 1/3 to the diameter of aortic annulus. There are 2 situations in small VSD if patient is asymptomatic. What is the meaning of asymptomatic? When there is normal pulmonary arterial pressure, or there can be normal left heart chamber and there is no sign and symptom in the patient. So these type of VSD close spontaneously. They close spontaneously. No intervention required. They close spontaneously. Most frequently till the age of 2 years. till 2 years of age. So till then, what we have to do? We should follow up the child bi-monthly for 8 weeks. That means for 2 months. And then we should follow up 6 monthly till the age of 2 years. Most of the small asymptomatic VSD close by the 2 year of age. And till then we should follow up the child. What we should look? We should look for weight gain, whether child is gaining weight or not, any chest infections, and onset of any new murmur. Most of the small asymptomatic VSD close spontaneously. But if child is symptomatic, there is signs and symptoms are present, or if there is endocarditis episodes, development of aortic regurgitation, or development of right ventricular outflow tract obstruction, or if there is past history of subacute bacterial endocarditis, then it should close as soon as possible. Prompt closure. So this was the management of small VSD. Mostly small VSD close spontaneously. Now moderate VSD. The moderate means the diameter is between 1/3 to 2/3. They do not close spontaneously. They should always need treatment. They should always need closure. But if patient is asymptomatic, or if patient is symptomatic but controlled on medications, so will not hurry in the closure of the VSD. Closure of VSD definitely required, but we'll wait for some time. We'll do periodic medical follow-up. We'll give nutritional support to the child to prevent failure to thrive. And if there is any infection, then treatment of respiratory infections. We'll wait for some time and then closure 1 to 2 years of age. But if there is significant hemodynamic compromise, or if there is left ventricular dysfunction, so then closure should be done as soon as possible. There is surgical closure. Now about the large VSD. In large VSD, surgical closure is essential. So still two situations. If congestive heart failure, CHF, and closure as soon as possible. But if CHF controlled with medication and closure by the age of 6 months. They will definitely need closure, but if CHF is controlled, we can wait till the age of 6 months. It is important to know the indication of surgical closure. It is also a separate topic, indication of surgical closure of VSD. So we'll discuss it here only. So first indication is patient at any age with large defects. Large defects always need surgical closure. So patient with any age with large defects, in whom clinical symptoms and failure to thrive cannot be controlled medically, or in whom the defect is not decreasing in size. So we should close as soon as possible. Or patient between age of 6 to 12 months with moderate to large VSD. Associated with pulmonary hypertension. So patient between age to 6 months, if they are having moderate to large VSD along with pulmonary hypertension, they should done with surgical closure even if symptoms are controlled with medication. Patient between age of 2 to 5 years. If VSD, if symptoms are well controlled but QP-QS ratio more than close to 1. That means pulmonary vascular resistance is so high, it is double the resistance of systemic circulation, so they should close spontaneously. If age is more than 5 years, but there is development of aortic regurgitation. They should close spontaneously. So what are the therapies available for management? Medical management. This is only for management of CHF. Congestive heart failure. We can use diuretics. We can use AC inhibitors. Or we can use digoxin. So it is only for management of CHF. And the surgical approach are transcatheter device closure, surgical, or nowadays hybrid surgeries are in. So hybrid surgeries are available. It is the combination of transcatheter device closure and some surgery. So 4 types of therapies available for management.